Welcome to the Diabetes Risk e-learning management program. This module consists of a roundtable discussion between international experts in the field of macrovascular diabetic complications, which runs in parallel with a visual presentation highlighting important aspects of the discussion. Instructions. This e-learning module is a Category 2 RACGP accredited program for the QI and CPD 2011 to 2013 triennium. To be awarded 2 points, you must complete the e-learning module and complete an evaluation form. Please note that the QI and CPD points cannot be awarded unless you complete the evaluation form. Please remember to include your QI and CPD number. Additional information is provided via a hyperlink available on this webpage with the e-learning module. Click on the link if you'd like to view descriptions of the trials discussed. Learning objectives. At the conclusion of the session, you will be able to review the management of dyslipidemia typical in diabetic patients as part of managing macrovascular risk beyond traditional risk factors. Consider the residual vascular risk of patients treated to LDL cholesterol target with statin therapy, and understand the safety and tolerability of combination lipid-lowering therapy.
Ladies and gentlemen, dear colleagues, my name is Alberto Zambon and I'm a lipidologist from the University of Padua in Italy, and it is my pleasure today to welcome you to this roundtable on optimizing diabetic management beyond traditional risk factors and LDL cholesterol control. Is there a macrovascular benefit? We are privileged today and have the unique opportunity to have a panel of 3 distinguished guests who are leading international experts in the field of macrovascular diabetic complication. Professor Lale Tokzoglu, cardiologist from Ankara, Turkey. Professor Henry Ginsberg from New York, endocrinologist, part of the PI on the Accord lipid trial and steering committee member of the Accord study. And Professor Anthony Kitch, a cardiologist, expert in cardiovascular disease and diabetes, also lipidologist, principal investigator in the field trial, and part of the steering committee of lipid as well as the heart protection study. Welcome to you all. Today's topic, macrovascular complications in patients with type 2 diabetes, represent a major burden for our patients with diabetes in terms both of morbidity and mortality, as well as a massive healthcare problem due to the high cost invested for managing cardiovascular disease in patients with diabetes. Now, focusing on macrovascular disease, there is a general agreement that LDL cholesterol should be the main target. And LDL cholesterol lowering with the statin-based regimen is the top priority to reduce cardiovascular disease in patients with type 2 diabetes. Now, although LDL lowering and statin treatment are highly effective in reducing cardiovascular events, still the events are seen in patients on a statin treatment. Lipid control is a key component of what must be a multifactorial approach to prevent macrovascular disease in patients with diabetes. Statins are definitely the playmaker when it comes to lipid control in patients with diabetes, but a healthy lifestyle and a good blood pressure as well as a good glycemic control are key components of this multifactorial approach and are all associated with a significant decrease of macrovascular events in patients with type 2 diabetes. In fact, recent trials stopped questioning the issue of whether this multifactorial approach is beneficial in terms of macrovascular events. Rather, they are focusing on a different question. Is intensive control of these risk factors rather than conventional providing a better outcome, which means a greater decrease in macrovascular events? One such a trial, I believe, is the Accord trial, and we're fortunate enough today to have Professor Henry Ginsberg, who is the principal investigator of the Accord lipid as well as steering committee member of the Accord trial. Professor Ginsberg, could you give us an insight of what was the clinical question behind the Accord trial today?
Yes, thank you, Alberto. As you mentioned, we're at the point now where we're interested in looking at whether more intensive therapeutic goals have a benefit compared to the standard therapies. And specifically in the ACCORD trial, the design was focused on 3 research questions: whether intensive glucose control would be better than standard glucose control, whether intensive blood pressure control would improve outcomes compared to standard control, and whether intensive combination therapy of the diabetic dyslipidemia would improve outcomes compared to statin therapy alone. This was a very large, multi-center trial with over 10,000 people.
Harry, what are the key messages of ACCORD? In other words, is intensive blood pressure and intensive glucose control providing extra reduction of cardiovascular events as compared to the more conventional approach?
Well, unfortunately, in ACCORD, both of those questions turned out in the negative. That was specifically in patients with type 2 diabetes with high risk for cardiovascular events. Trying to reach a hemoglobin A1C of less than 6% had no benefit compared to having an HbA1c of 7.5%, and in fact, there was an unexpected increase in total mortality over the first 3.5 years of the trial. In terms of blood pressure, there was a trend toward benefit overall, with a goal of a systolic blood pressure of 120 compared to a systolic blood pressure goal of 135, under 140, but it did not reach statistical significance. However, in this, one of the secondary outcomes was specifically fatal and non-fatal stroke. There was a 40% reduction in the more intense blood pressure arm.
Harry, you are the principal investigator of the ACCORD lipid arm. Let's focus on the ACCORD lipid arm then. What was the clinical rationale behind this study?
Well, as you mentioned, the diabetic population has a markedly increased cardiovascular risk burden, and even after reaching LDL goals in all of the trials, diabetics always have higher event rates. And so in the ACCORD lipid arm of the overall ACCORD trial, the specific question was whether the combination of a fibrate with a statin would reduce cardiovascular events compared to a statin alone. There were 5,500 plus patients in this trial, and all of them received simvastatin between 20 and 40 milligrams a day, depending on their cardiovascular status, and then they were randomized to either receive placebo or fenofibrate. And the trial had a mean follow-up of 4.7 years.
Right. I think the key question also is, what were the baseline characteristics of patients in the ACCORD lipid test?
Well, this was a population chosen for high risk of cardiovascular disease. And so it was an older population, mean age of 62. We had about 1/3 of the patients were women. About more than 1/3, 37%, had had a prior cardiovascular event, and all the others had multiple risk factors or clinical cardiovascular disease without a full event. It's of interest to look at the lipid levels. We did not try, for a number of reasons, to only study dyslipidemic diabetics. We enrolled across the entire range of the population with diabetes. LDL cholesterol at baseline was about 100 because 60% were on statin, and then HDL was low, but triglycerides were only a little bit above average.
I think the key question, Harry, now is ACCORD lipid providing support for the use of combination simvastatin fenofibrate in all our diabetics?
So here we can see the overall result, and it was disappointing. As you can see from the curves, there was really no significant difference between the two groups in the event rates, and those are shown there. And the hazard ratio was 0.92, which was not statistically significant, not even close. So the overall conclusion was that the use of fenofibrate together with simvastatin in a general way for all diabetics is not something we should be doing, that it did not have a benefit in the majority of patients with type 2 diabetes at high risk.
I think there was a subset of patients that did receive a somewhat greater benefit from the combination therapy.
Well, in any trial, you wish to look beyond the overall result, and this was a very heterogeneous group of individuals with a broad range of plasma lipids at baseline, as I mentioned. When we looked across the lipid levels of LDL, of HDL, of triglyceride, what emerged from this analysis was that those patients, about 17% of the patients in the trial with a high triglyceride in the upper third or a low HDL in the lower third, that combination did have benefit of about a 30% reduction in events compared to the placebo group.
Okay, Harry, if I understood correctly, so there is a subset of patients that may receive indeed a greater benefit from a combination of simvastatin, fenofibrate, as compared to statin monotherapy. Now, I'm curious, are these patients with low HDL and high triglyceride at higher cardiovascular risk than the overall population you saw in Accord? And can you further comment on the effect of combination in this particular subset?
This slide demonstrates just that point, and we were quite surprised. The highest event rate overall in any subgroup were those people who had already had cardiovascular events, the secondary prevention group. And they had an event rate of about 18% over the course of the study. As you see on this slide, those with dyslipidemia had an event rate of almost as high, despite the fact that only 40% of them had had a prior event. So this group with dyslipidemia, the combination of low HDL, high triglyceride, had 70% more events during the trial than the rest of the subjects in the trial. And in terms of their benefit, shown here, now this was a group that made up, as I said, 17% of the trial. We think in the general population, probably 10 to 15% of people with diabetes have this combination. And you can see that they had a 31% reduction in their event rate when they were on Pheno and Simva versus Simva alone. And this meant that you only needed to treat 20 people to reduce events by 1.
I think there is evidence from previous trials that suggests that this population is indeed susceptible to greater benefits from fenofibrate, either monotherapy or in combination. Is that right?
Yes, and I think when we saw these results, we had to realize that this was a third level of statistical analysis. This was a subgroup analysis. It was pre-specified. So what was the evidence from prior studies, which were all monotherapy fibrate trials? And as you can see here, if we look at the Helsinki Heart Study, the bezafibrate infarction prevention trial, or the field trial, the first being positive, the second two being negative overall, when we look at subgroup analyses, post hoc analyses with similar lipid characteristics as our subgroup, we can see very striking benefit in all of those subgroups. So I think the historical basis for our finding is clear from these published papers.
Thank you very much, Harry. Well, it looks like there is clear information about Accord and previous trials that there is a subset of people with low HDL and increased triglyceride that are susceptible to benefit from fenofibrate, either as monotherapy or a combination with the statin. One such trial is the field trial, the largest trial so far in patients with type 2 diabetes. And we are fortunate enough today to have in our panel of experts Professor Tony Kitch from Sydney, who is the principal investigator of the field trial. Professor Kitch, could you provide us with some background information about the field trial and eventually with a comparison of differences and similarities between field and the Accord lipid arm?
Thanks, Alberto. Yes, the thinking behind tackling this question was the issue that we face in heart disease and stroke, that people with diabetes have a lot more of it than people without diabetes, and also the disease in the vessels is much more diffuse. As you can see on this slide, here is a patient with a right coronary artery that's been stented proximally, and you can see in the areas of the arrows that there is severe diffuse disease throughout the entire artery, which makes it very difficult to manage over the long term. Furthermore, we know that patients with diabetes are more likely to have a heart attack, around 3 times more likely than people without diabetes, less likely to get to hospital alive, less likely to leave hospital alive, and do more poorly after stenting and bypass surgery, revascularization procedures. They have more recurrent disease and poorer long-term survival. So with that in mind, we felt it was important to tackle the issue, specifically in patients with type 2 diabetes, where in fact there is a typical dyslipidemia, as you've mentioned, of low HDL and high triglyceride. Whilst in fact the levels of LDL cholesterol in the plasma of patients with diabetes are really very similar to people without. So it makes sense to look at a fibrate, and the field study was designed to assess the value of a fibrate in around 10,000 patients compared with placebo therapy. Now, to get into this study, patients needed to not have a definite indication for statin therapy in the late 1990s and have a wide range of lipid levels, including total cholesterol between 3 and 6.5 millimoles per litre, total cholesterol to HDL ratio of 4 or more, so a relative deficiency of HDL cholesterol, and a triglyceride level greater than 1 or around 90 milligrams per deciliter. Patients were then randomised between 200 milligrams of fenofibrate, which is equivalent now to the co-micronized 145 milligram preparation that's available in most countries, and compared against a matching placebo in a double-blind fashion until there were 500 primary endpoint events, which in the case of field was coronary death or non-fatal heart attack. The characteristics of the patients were very typical of patients you would see in your own diabetes practice or clinical care. Age of 62 years, early duration on average of diabetes, but ranging up to 16 years of diabetes, almost 40% women. HbA1c generally well controlled, around 7%, but up to around 10%, the majority having hypertension, some with albuminuria, and dyslipidemia being more common than not. High triglyceride levels in more than half the patients, and low HDL meeting the ATP3 criteria in around 60% of the patients. Now, when we compare those characteristics with the ACCORD study, obviously the field study was a little bit larger than the ACCORD lipid trial, and the difference, the key difference, is that in field we were assessing an intention to test fenofibrate monotherapy, although as you will see, during the course of the trial there was a lot of statin use taken up by patients, versus in the ACCORD trial where all patients received background statin therapy. The primary endpoints were similar, but the prior cardiovascular disease event rate was lower in field than ACCORD, and the diabetes duration was shorter with better glycemic control. As you would understand, with ACCORD being a study that actually was looking at improving glycemic control. And the cardiovascular event rate in field was somewhat lower than ACCORD for those reasons, that there was less prior cardiovascular disease and better diabetes control on average. You can see also that the numbers of women were similar in terms of proportions, but the rates of albuminuria are really quite different, consistent with the longer duration of diabetes in the ACCORD trial. And in fact, in the ACCORD trial, there was more dyslipidemia, more extreme dyslipidemia than there was in field.
Now, Tony, let's stick with this dyslipidemia issue. Is in field there the evidence that low HDL cholesterol and increased triglycerides, such an ACCORD, define the population at high cardiovascular risk, and that there might be a great benefit for fenofibrate and monotherapy for this specific population?
Well, that's exactly right, Alberto. That turned out to be the case. It's important to remember, of course, that just like in the ACCORD trial, in field the primary endpoint of the study was negative. It was in favour of treatment with an 11% reduction in the primary endpoint, but this did not reach statistical significance. In fact, there was a significant reduction in non-fatal myocardial infarction of 24% with a p-value of 0.01, but no significant difference in coronary death. Total cardiovascular events were significantly reduced by 11% with a p-value of 0.035, and coronary and carotid revascularization procedures were also reduced by 21% with a highly significant p-value. as were hospitalisations for acute coronary syndromes by around 18%, and clinical and silent MI together by 20%, which was highly significant. When we turn to then the question of the risk of the patients with the typical dyslipidemia of diabetes, you can see that in fact these were the highest risk patients with almost exactly the same 5-year event rate as was seen in Professor Ginsberg's ACCORD study. These patients with low HDL and high triglycerides had by far the greatest risk compared to other patients in the population. And in fact, the effects of fenofibrate were greatest in this population, just as was found in the ACCORD study, whilst the effects were significant statistically for patients with hypertension, low HDL, or metabolic syndrome. By far the greatest effects were seen in these patients with combined dyslipidemia, such that there was a 27% overall reduction in cardiovascular events in these patients, and a number needed to treat of only 23, with a p-value of 0.005, compared to the overall effect of 11% in the total population.
Well, thank you, Tony. I believe that the results you showed for lipids, lipoproteins handling in field and ACCORD lipid, agree in suggesting that there is indeed a population with low HDL and high triglyceride that may indeed benefit greater than the overall population from fenofibrate therapy. I think it's time to call into action our third guest, Professor Lale Tokuzoglu, cardiologist but with an extensive experience in lipoprotein. She's the Vice President of the European Atherosclerosis Society. Lale, do you have any comments on the interesting data that Professor Ginsberg and Professor Keach presented today?
Thanks, Alberto. I'd like to start by asking a question to Dr. Ginsberg. Did the effect of fenofibrate on serum creatinine levels affect the clinical outcome in the ACCORD study?
So, to address that, I'd like to look at the overall adverse event profile. First of all, based on some of the findings in the field trial, we focused on gallbladder-related disease, on deep vein thrombosis, pulmonary emboli, and we saw no signals at all of toxicity. We also, of course, because of the long-standing concerns with statins and fibrates about their effects on liver function, looked carefully, and both ALT greater than 3 times the upper limit of normal, the rates were very low and not different between the two groups. The rates of ALT greater than 5 times the upper limit of normal, even lower and slightly higher in the pheno-Simva group versus Simva alone, but very low rates. Of course, we're always worried about myositis and effects of both of those drugs, and particularly the combination. And we looked at creatinine kinase levels greater than 5 times or greater than 10 times the upper limit of normal, and saw no signal at all. When it came to renal function, as had been seen previously in other trials with fenofibrate, we saw an increase in creatinine levels. In order to be enrolled in the trial, you needed a creatinine less than 1.3 milligram per deciliter for a woman or 1.5 milligram per deciliter for a man because of the metformin guidelines, and everyone was going to be on metformin in this study. During the trial, twice as many men and women had elevations of creatinine over those limits if they were on fenofibrate and simvastatin versus simvastatin alone. Obviously, these were older diabetics with a lot of vascular disease, their creatinine levels went up, but twice as many people had elevations of creatinine if they were on fenofibrate. So we did see that expected outcome.
Dr. Keach, did you have the same observation in the field trial?
Yes, we had exactly the same situation, where in fact there was a very early rise in creatinine with fenofibrate. In fact, in the field study there was a 6-week active run-in period before randomization in which both groups received fenofibrate, and you can see that creatinine went up quite rapidly over that first 6 weeks. And then amongst patients randomized to continue with 5 years of fenofibrate, creatinine remained elevated compared to the placebo group. Interestingly, however, at the end of the study there was a complete reversal of that creatinine rise back to below the placebo group at the end of the trial, such that there was no concern that this represented nephrotoxicity.
Lali, if I may step in, I have a question for Professor Kitch. Data on the reversal of the creatinine levels are pretty reassuring, but are you positive that there is not an increase in cardiovascular events associated with such an increase in creatinine?
Well, that's a very good question, Alberto, and in fact we saw no difference in the cardiovascular events amongst patients with a large elevation of creatinines compared to people with a small elevation of creatinine. And we split the patient population of almost 10,000 patients into tertiles of how much the creatinine rose over the first 6-week pre-randomization active run-in period. And in fact, we saw the greatest cardiovascular benefit, which was separately statistically significant amongst those patients with the largest creatinine rise. And it may in fact be a marker of bioactivity of the drug. So certainly it was extremely reassuring. There was no excess of cardiovascular events related to use of fenofibrate in people who had a large rise in creatinine, nor in fact was there an excess of renal events in such patients.
Well, thank you, Tony, for this very reassuring answer. Let's put all these clinical interesting information into practice. Lala, you're involved in the writing and reviewing on international guidelines. Now, the current guidelines strongly support LDL cholesterol as the main target and LDL cholesterol lowering with statin therapy as the top priority. On this background, is there any room left for the low HDL and triglyceride as a target, actually?
Well, even when they're at LDL goal, patients with cardiometabolic disease remain at high risk for cardiovascular events. A large meta-analysis of 18,000 diabetics on statin treatment has shown us that 1 out of 7 of these patients suffer a cardiovascular event within the next 5 years. And some of this residual risk may be explained by atherogenic dyslipidemia. Now, atherogenic dyslipidemia is quite commonly seen in insulin-resistant states, such as diabetes, metabolic syndrome, or obesity. And it is characterized by increased triglycerides, low HDL, and small dense LDL particles who are more atherogenic. Both high triglycerides and low HDL have been shown to contribute to cardiovascular risk independent of LDL cholesterol levels. The Emerging Risk Factors Collaboration looked at 68 prospective long-term studies in more than 300,000 patients and showed us that there was a strong negative association of HDL cholesterol with cardiovascular risk. And this persisted even when adjusted for other risk factors. Now, there was also a correlation with triglycerides and non-HDL cholesterol with cardiovascular risk. However, the association of triglycerides decreased somehow when corrected for HDL cholesterol and non-HDL cholesterol. Both this analysis and others have shown us that non-fasting triglycerides are also an indicator of cardiovascular risk because they show us the remnant status of the patient. The contribution of triglycerides and HDL to cardiovascular residual risk after you have reached LDL cholesterol goals was recently assessed in a case control study. And in this study, the patients reached the LDL goal of 70. Both triglycerides and HDL synergistically contributed to cardiovascular risk in these patients. So I think there's still room for improvement after you have reached your LDL cholesterol goal.
Thank you, Lali. Following up on that statement, are there threshold levels of triglyceride and HDL cholesterol beyond which we should consider a combination therapy and also targets we should achieve?
Both the American guidelines and the European guidelines, of course, take LDL cholesterol as their priority. But after you have reached that, the NCP looks at non-HDL cholesterol, whereas the European guidelines, the 2007 European guidelines, show triglycerides more than 1.7 millimole per liter and HDL less than 1 in men and 1.2 in women. as markers of risk without specific goals and aims. But it's reasonable to say that if a patient with cardiometabolic disease has triglycerides more than 2.2 and HDL less than 1, this is a high-risk situation that needs to be addressed. So after targeting and getting the lifestyle measures and ruling out secondary causes, it would be reasonable to start combination therapy in these patients.
Thank you. How often, since the relevance that is given by the guidelines to the low HDL and high triglyceride as a secondary target, then I think the following question is, how often do you see these patients in clinical practice? Are they rare or it's a common population?
Actually, atherogenic dyslipidemia is quite prevalent in the population, and as our population ages and becomes more obese, this is really becoming an issue. When you look at the NHANES registry from the United States, you see that the abnormal LDL is decreasing, whereas abnormal triglycerides plus HDL lowering, having low HDL is on the rise. Abnormal triglycerides have tripled in the past 3 years in the elderly. And the situation is not so much better in Europe. When you look at the EUROSPIRE 1 to 3 studies, you see that over the past 10 years, Europe has gained about 5 kilograms, has more central obesity, and the diabetes prevalence is on the rise. And this is all in a setting of increased medication use. In the EUROSPIRE 3, when we looked at patients who had been hospitalized with coronary artery disease, even in that population, we saw that more than a third of the patients had low HDL and high triglycerides.
Well, thank you. So it looks like the guidelines support combination therapy in this specific subset of people. These patients are quite commonly seen in clinical practice. How should they be followed up, both in general terms as in terms of safety issues?
Safety considerations for statin fibrate combination therapy. In terms of safety, we have to consider the potential risk of myopathy and rhabdomyolysis with the statin fibrate combination. This was first reported in 1990 with the combination of gemfibrozil and lovastatin. Pharmacokinetic considerations for statin fibrate interaction. The increased risk of myopathy and rhabdomyolysis with combination therapy, aside from the simple additive effect of each separate agent, is thought to be related to the inhibition of statin glucuronidation. Glucuronidation eliminates the active hydroxy acid metabolites of simvastatin, atorvastatin, and cerevastatin. Evidence suggests that gemfibrozil inhibits statin glucuronidation, whereas fenofibrate appears to have significantly less inhibitory effect on statin glucuronidation, which may explain the lack of significant drug interaction between fenofibrate and statins.
Well, at the initiation of therapy, it's a good idea, in addition to the lipid profile, to measure the CK, creatinine, and serum transaminase levels. And the transaminases and CK, creatinine should be repeated 8 weeks later. But if you up-titrate the dose of the statin, of course you need to repeat again. And if the serum transaminases are less than 3 times normal, then you do not need to repeat them, only do them yearly thereafter. As for CK, no routine CK measurements for follow-up are necessary unless the patient has myalgia or risk factors for myositis, such as chronic renal disease, old age, diabetes, hypothyroidism, etc.
Well, thank you, Lala. So it doesn't look only that guidelines support combination therapy in a specific subset of people, but the safety background of fenofibrate and simvastatin as a combination approach is pretty strong.
Management of dyslipidemia. In addition to the statin fibrate combination that we have discussed, there are of course other therapies that may be used as monotherapy or in combination in the management of dyslipidemia. Here we can see some of the combinations that have been evaluated in the treatment of dyslipidemia.
I think we have time for a few questions open to all our distinguished guests. One such a question comes up from the Accord trial, and I think has some implication in the field as well. Is there any gender issue or differences in the results coming out from the Accord lipid arm, Henry, and then I believe Tony can follow up looking at the field data into this topic, actually.
Yes, in the subgroup analysis in Accord, aside from the dyslipidemic group, the only other subgroup that we saw an interaction, a difference, was in gender. And men did much better than women. We were surprised by this, but it was clearly a differential outcome. Women on fenofibrate had clearly no benefit and tended toward a bad outcome, whereas the men had a benefit. When we looked further at this, at the dyslipidemic group, because that was our group where we had benefit as a group, we saw that women with dyslipidemia, who had the same exact lipid levels actually as the men with dyslipidemia, seemed also to benefit. In the non-dyslipidemics, the women actually looked like they did not do well at all, whereas the men still had at least no harm, but not much benefit. So I do think this was unexpected. We don't have a plausible reason for it. You're always worried about subgroup analyses, but it is something we're thinking about. At least though in the dyslipidemic women, it appears that they certainly are in the direction toward benefit.
All right. Tony, is there any evidence that such an effect is seen in the field as well?
Well, in fact, Alberto, we didn't see the same thing in field, interestingly. And in fact, overall, the benefit was somewhat larger in women than men. And in fact, in both the dyslipidemic and non-dyslipidemic women, fenofibrates seem to offer similar magnitudes of benefit. And in dyslipidemic men, as you can see, the benefits were larger than for non-dyslipidemic men. Overall, benefits in both men and women are suggested using fenofibrate. So I think it is difficult to be certain that there's any concern about using fenofibrate in women. In field, irrespective of dyslipidemia, women seem to get particular benefit, in the absence, of course, generally of statin therapy, whereas in Accord there was background statin therapy.
Well, thank you, Tony. Another question to end up the debate. You provide, all of you, reassuring data about the safety of combinations simvastatin fenofibrate. Now, I know that in the clinical setting, a lot of colleagues are still afraid. They have concerns when they think about fibrates combined with statins. We know that gemfibrozil was responsible for most of the adverse events of this combination, but could you provide, both coming from your studies as well as your clinical daily experience, reassuring information about the safety background that is associated with the fenofibrate statin combination?
Well, what was striking in the Accord trial was that subjects who complained of moderate to severe muscle pain and had any elevation in CK levels comprised 40% of both groups, the placebo group and the fenofibrate group. So clearly many people complain of muscle aches and pains. There are a lot of reasons for CK levels to be elevated, a game of tennis in the sun, but we saw absolutely no difference between the two groups. We had no rhabdomyolysis, and as I showed you, the levels of CK above 3 or 5 times the upper limit of normal were very low and no different between the two groups.
Any further comments from
Well, I think
I
think in field we saw have a similar message. By the end of the study, around 1,000 patients in the field study were receiving statin therapy in combination with their trial medication, being fenofibrate, and we saw no concern with rhabdomyolysis at all. So I think unlike the combination with gemfibrozil, the pharmacokinetic studies support that there isn't an important interaction between the use of fenofibrate and statin metabolism for the majority of patients.
Well, given the fact that you're involved in guidelines writing and reviewing, do you think your perception of a combination fenofibrate and statin is backed up by a good safety record, even at the guideline levels?
I think so. If you monitor the patient well, and if you're very careful about polypharmacy and other underlying clinical situations, especially in fragile patients, it's all right.
Right, but Thank you very much, all of you, for your great contribution on the state of the art and latest findings on prevention on macrovascular disease in diabetes. I think what we learned today is that the multifactorial approach to reduce cardiovascular events in diabetes is a mandatory approach. We know that the LDL cholesterol reduction by the use of the statin remains the top priority, supported by all the guidelines. On the other hand, on optimal LDL cholesterol levels, the risk of cardiovascular events remains elevated, specifically in patients with diabetes characterized by low HDL cholesterol and increased level of triglyceride. A combination of the statin and fenofibrate reduces cardiovascular risk in patients with diabetes and low HDL and increased triglyceride. Now, this ends up today's roundtable. I'd like to thank you all on behalf of distinguished speakers in the panel. Thank you again for your kind attention.
To summarize the key outcomes from the e-learning module, reduction of LDL cholesterol is a priority which is supported by national and international guidelines. However, despite optimal LDL cholesterol reduction, the risk of cardiovascular events may remain elevated in diabetic patients with dyslipidemia, characterized by elevated triglycerides and low HDL cholesterol. In these patients, the combination of simvastatin and fenofibrate may be useful in reducing the residual cardiovascular risk. The risk of adverse events, specifically rhabdomyolysis with combination therapy, is dependent on the statin-fibrate combination used. This is an important consideration when prescribing combination therapy. DREAM. The DREAM program is RACGP accredited for the 2011 to 2013 triennium. To be awarded the 2 Category 2 points, you must now complete an evaluation form. Next steps. To complete the evaluation form, click on the link on this webpage. Please note that QI and CPD points cannot be awarded unless you complete the evaluation form. Please remember to include your QI and CPD number.